Okay. Next is about the pancreatic disorders. Now, pancreas is a very important organ which is both exocrine as well as endocrine. It has the components of exocrine as well as endocrine components. The location, of course, the basic anatomy, around you know about it. The certain of the important issue is its relationship. It has a close relationship with the duodenum in the duodenal sea curvature, and the pancreatic duct system, the exocrine secretions would be collected in the back this pancreatic duct system, which is a acinar gland system, and these enzymes are secreted into the duodenum whenever there is a need, and the control of this, regulation of this would be by the pancreatidymin enzyme, CCKPZ, cholecystokinin and pancreatidymin. These are the two paired enzymes as such, which is secreted by the duodenum, and the secretion is controlled by the same, and the sphincter of OD, the sphincter there, it regulates the flow of these, whereas the endocrine component, which is present in the interstitial area, which are also called as islets of Langerhans, these islets are having the alpha and beta cells, and which secrete both insulin as well as a glucagon. Insulin regulates the glucose level, and the glucagon regulates reduces the glucose level, so they balance the glucose level in the body. And though these endocrine functions are of the pancreas, usually diabetes mellitus is not considered as a pancreatic disorder. Instead, it's categorized as a metabolic disorder, whereas type 1 diabetes is often produced due to a pancreatic pathology. That's the other controversial issue. Now the secretions, the enzyme secretions, exocrine secretions are from pancreas. There are many. Among them, the most important is the trypsinogen. See, trypsinogen is a very powerful proteolytic enzyme which is absolutely necessary for the product, this breakdown of the protein which is consumed. It's the most powerful, and trypsin in a very active form would be very strong, very potent proteolytic. Even a drop of trypsin would be enough to digest the whole surface of the body. And the important is trypsin is presented or synthesized and stored in the pancreatic cells in the form of trypsinogen, and only after its secretion into the intestines, trypsinogen gets activated into trypsin and chymotrypsin, and this helps in the digestion of the protein. And this phenomenon is a very important phenomenon because trypsinogen is an inactive form of the trypsin. Pancreas stores this in the form of an inactive form, that's the trypsinogen, and then only after its secretion it produces it gets converted into trypsin. Similarly, you have many of these nucleases and elactase enzymes which dissolve or which destroy the substances, protein as well as carbohydrate. So chymotrypsinogen and carboxypolypeptidase. So one set of these enzymes is quite important in the pathology of the diseases, where the inactive form of these enzymes would be presented in the pancreatic tissue, and after their secretion they become activated and they produce the digestive activity. In addition to that, enterokinase, which helps in the this movement of the intestines, as well as it's also necessary for the conversion of trypsinogen into trypsin, which is actually secreted by the small intestines, but still it has a relationship with the pancreas. So some amount of that is secreted by the pancreas. Then the amylolytic enzymes, these are again few hydrolyzing enzymes which help in hydrolyzing glycogen and carbohydrates, as well as to a certain extent the disaccharides. And then lipolytic enzymes like lipase. Lipase is another of the, so amylase and lipase. The other two enzymes which are comparatively not so active as that of the trypsin, but they are necessary for the digestion of the protein and the fat. Amylase mainly for the digestion of the glucose, the carbohydrates, and lipase for the digestion of the fat. So it breaks down the fat into fatty acids as such. Whereas the hormones which are presented in the protein, these pancreas are produced from the pancreas are mainly insulin and glucagon. In addition to that, somatostatin and polypeptide also is secreted. They have comparatively less important role. Somatostatin is mainly, it inhibits the insulin and glucagon release. Both are suppressed, and pancreatic peptide is mainly has a role in the having that appetite, feeling of appetite. So it is directly have a role on the appetite stimulating center of the brain, and this has that having that feeling of appetite is the other important issue. But comparatively, compared to the role of insulin and glucagon, which are secreted by the beta and alpha cells, which have a major role to play with the maintenance of the glucose level in the body, the somatostatin and pancreatic peptides, polypeptides would be having a lesser role. The mechanism of maintenance of the glucose level is by two ways. Whenever there is a lesser glucose level in the body, the glucagon would be activated, and it produces glycogenolysis. The glycogen in the store in the intestines would be converted in, broken down into glucose, and hence it increases the glucose level. At the same time, if at all there is a increased glucose level, then the insulin gets activated, which helps in converting glucose into glycogen, and it gets stored in the liver as such. So this mainly the major role of insulin and glucagon is a conversion of glucose into glycogen and a breakdown of the glycogen into glucose, and hence maintenance of the sugar level. That's in brief about the physiology. Then we directly go into the diseases of the pancreas. Among the diseases of the pancreas, one of the important and congenital genetic disorder is a cystic fibrosis. And the incidence of cystic fibrosis is not very low. And another important reason is also one of the diseases where it produces multisystemic involvement. The incidence varies from 1 per 377 live births in parts of England to 1 per 97 in Asian live births. In comparatively, in India, compared to Western countries, the incidence of cystic fibrosis is lesser, whereas in Western countries it is more common, more frequent, and it's caused by a specific gene and in the chromosome 7, which is also called as CFTR gene, CFTR, cystic fibrosis transmitting gene. And it important whenever there is a cystic fibrosis, what happens is the amount of pancreatic enzymes secreted would be lesser, particularly trypsin enzyme would be either absent or lesser, and because of that, at the same time, it also affects the secretions in the other organs like the lungs. They quite important in the lungs, and then the genital organs and intestines, liver, and so on. In the other, so there is a involvement of multi-organ involvement, which results in the fibrosis. Most of the times the diagnosis occurs at the time of the birth itself, because the basic issue of that CFTR or the mechanism of producing this involvement in the lungs is the CFTR protein, which is the protein which is necessary for this cystic fibrosis transmission condition. It acts as a channel for flow of oxygen in the lungs, and in the presence of that, the flow of oxygen would be free. But if it is absent or if it is reduced, the flow of oxygen across the membrane in the lungs would be affected, resulting in a reduced oxygenation and then consequent changes of accumulation of the fluid over the lungs, edema changes like pulmonary hypertension occurs, and then there is a fibrosis of the lung tissue. So the whole pathology starts with a reduced exchange of the oxygen in the lungs. At the same time, it also is necessary for the secretions of the intestines, and hence the most common clinical presentation, early presentation of the cystic fibrosis is the meconium ileus. The stools would be hard. The meconium, the firstborn, the newborn, would not be able to pass the stools because the stools will be harder. Then at the same time, because of the involvement of the lungs, there would be fibrosis. So if you take an X-ray, now of course this is a later time X-ray, So the newborn, the symptom would be meconium harder and resulting in meconium ileus, many of the conditions. The child would not be able to pass the meconium easily. And then there is next is about the respiratory issues. Respiratory issues could occur at the time of the birth or maybe at the later ages. And in the later ages, typically it presents with the fibrosis in the lungs, which can be seen in the X-rays. Typical cystic fibrosis X-ray would show that fibrous tissue markings, dense fibrous linings over the area, and the reduced ventilation. The amount of the air entering into the lungs would be lesser. In a CT scan, that fibrosis would be seen as a multiple, that thickening of the membranes of the tubules is very characteristically seen in case of the cystic fibrosis. Now, this radiological appearance of the cystic fibrosis is very characteristic. In the very advanced stages, you will see that these advanced interstitial changes in the lungs, in the chest X-ray, same seen in the CT scan as such. That's about the images, right? The other clinical symptoms in case of the cystic fibrosis are meconium ileus is one of that symptom which is seen in early stages. The other symptoms which would occur would be, there can be nasal polyposis or sinusitis-like conditions, rectal prolapse, chronic diarrhea, chronic pancreatitis, cirrhosis, and or other forms of hepatic dysfunction. The most common clinical symptom would be the respiratory complaints, because patient would have reduced the exchange of the air in the lungs become fibrosed and their expansor capacity would be lesser. So the patient would be susceptible for respiratory infections, often it ends up in bronchiectasis or interstitial lung disorders. So the most common clinical symptom in the later part of the life would be the pulmonary symptoms. In the early part of the life would be meconium ileus or the harder stools. The other clinical symptoms which could occur could be the nasal polyps, sinusitis, prolapse, diarrhea, pancreatitis, cholelithiasis, cirrhosis, or other forms of hepatic dysfunction. These are comparatively less common and often misleading symptoms also, but any of these symptoms to occur. In a patient who has a chronic respiratory complaints, which we usually diagnose as COPD, if at all the patient has the other coexisting symptoms like diarrhea, pancreatitis symptoms, gallbladder stones, chances of the cystic fibrosis would be more. The diagnosis of cystic fibrosis is done by the major three important issues: the typical chronic obstructive pulmonary disorder, documented exocrine pancreatic insufficiency. That pancreatic insufficiency has to be demonstrated by either assessment of the lipase and amylase, or more specifically trypsin assessment. Trypsin assessment in the stools is done now by a biochemical test which is quite advanced and complex. In the earlier days, or maybe one of the easy alternative to make out these trypsin in the stools would be, if you dissolve the stools in water and apply it over a old X-ray plate, wait for 10 minutes, wash out. If that stool solution washes up the pigments over the X-ray plate, the X-ray plate becomes clear. Then of course you have to use the polyfiber X-ray plate, that semi-transparent X-ray plate has to be used. If the pigments which are present over the X-ray plate are washed up, that shows the presence of the trypsin. If it is not washed up, if it is not affected, then the trypsin is absent. So in a patient with this pancreatic cystic fibrosis pathology, the stools would not be able to wash off the pigments from the X-rays. Suppose if at all you have old X-ray plate, and if you want to clean that X-ray plate or to have a transparent sheet, one of the option would be dissolve the stools, apply it over, wait for 10 minutes and wash off. If your stools have the trypsin and if you do not have the cystic fibrosis, the X-ray plate becomes clean. Anyway, that's about it. And then there is a positive family history. Very often it tends to occur in the families because of that genetic transmission, and particularly if one of the siblings has a disease, it can be made out. Another test which is now becoming popular to confirm cystic fibrosis is the sweat chloride test. Of course, it's not done very regularly. Sweat chloride test requires a very sophisticated setup. Very few centers are able to do that test. So that could be another of the tests which confirms the cystic fibrosis. The diagnosis of cystic fibrosis is usually done in pediatric conditions, and the maximum, the median age of diagnosis is by 6 to 8 months, and 2/3 of the patients are diagnosed by 1 year of age. That's very important. And cystic fibrosis, because it involves multi organs, and there will be always multiple complications. Most common respiratory complications. At the same time, there is a possibility of involvement of the other organs also, blood vessels also, and hence with all the effective treatment now, the average survival period, median survival period is 36.9 years. So that's the important issue. In a patient who has a repeated respiratory infection in case of the cystic fibrosis, the common organisms which are seen in the lungs are Haemophilus, Staphylococcus, Pseudomonas, and Burgdorfia and Escherichia Klebsiella. All of them are difficult to manage, and most of them they develop easily resistance to antibiotics, and hence the treatment often fails and the prognosis becomes poor. So cystic fibrosis will have comparatively poor prognosis. The main treatment, the principal goal of treating this cystic fibrosis is to maintain the normal lung function. So you may do anything to maintain the normal lung function as far as possible. The respiratory infection has to be clear. So the exercises to, as you treat any case of bronchiectasis, it has to be for postural drainage and prevention of exposure to the irritants. That lifestyle modification is the issue. And then of course the nutrition, because the patient would have a abnormality of the enzymes, digestion of the fat as well as the proteins would be affected, and hence supplements, enzyme supplements, vitamins are the other is the basic issue of management. There is no other curative management for the cystic fibrosis. Complications, whenever they occur, they have to be managed like. And the other drugs which are often used are pancreatic enzyme supplements, multivitamins, mucolytics, which help in making this sputum thicker, nebulization, inhaled or intravenous antibiotics, any of that antibiotics if at all necessary based upon the conditions, bronchodilators, anti-inflammatory agents, or the agents to treat the associated conditions or complications like insulin, and device to potentially reverse the abnormalities in chloride transport like sodium chloride often is given. But the majority of the patients which we have seen and which we could manage better would be by Mrityunjaya Arogya Makadwaja with the LS Mishrana, Lavasudha Mishrana. With this, the respiratory complications can be minimized and the patient would have a better quality of life. I don't say that cystic fibrosis can be cured, but I have many patients of fibrosis who have crossed the age of 40 or 50 and still surviving. They may have to continue the medicines for the lifelong. Makadwaja Lavasudha Mishrana is one of the maybe a better option to manage the respiratory complaints. That's about the cystic fibrosis. Next of the condition is the acute pancreatitis. Acute pancreatitis is a condition which can be acute emergency also. It can be medical emergency, can present with the very rapidly growing or rapidly changing clinical presentation, and hence the accurate diagnosis is important. The causes for that would be, the most common cause is alcohol. More than 70% of the patients would have the history of a prolonged alcohol consumption in case of the pancreatitis, and hence it is considered to be the most common cause. The other causes which can be that are a recent operation, abdominal surgeries, or any other invasive procedures where the pancreas will be handled. Trauma to the pancreas, road accidents or other injuries also to the pancreas also can be triggering the pancreatitis. Family history of hypertriglyceridemia, patients who have the high level of triglycerides, and quite important is very high triglycerides like more than 1000 milligram% would be often related to the episode of acute pancreatitis. So that increased triglyceride level and pancreatitis, their relationship is known, and it may not occur in the moderate rise in the triglyceride level. When it goes to very high level like 1000 milligram, then it can be triggering this pancreatitis. Viral infections also are known to produce the pancreatitis, and there could be a hereditary history, a hypercalcemia, any reason when the serum calcium level could be raised. Either it could be a pathology of parathyroid gland or any other metabolic pathology, or simply excess of consumption of the calcium also can trigger the pancreatitis. A increased serum calcium level also is another common coexisting factor in case of the pancreatitis. Patients who have a gallbladder pathology, particularly stones, crystals, they have a high risk of developing pancreatitis. As the stones pass through, there could be acute pancreatitis, and every patient of acute pancreatitis, you need to investigate and rule out the presence of the gallbladder pathology, and the whole approach to the management would be varying. If the patient has a gallbladder pathology like a gallstone and pancreatitis, the primary approach to the treatment would be the gallbladder has to be removed. Whereas in the other pancreatitis conditions, the approach to the treatment would be different, and hence that's important. And pancreatitis also is known to occur in patients who have a congenital variations of the pancreas, like annular pancreas or ectopic pancreatic tissue. In these conditions also, pancreatitis incidence is more. Drugs are known to, many of the drugs, and among those drugs, many of the drugs are known to produce the pancreatitis, and the definite association of the drugs which produce the pancreatitis. These are the list of the drugs like azathioprine, sulfonamides, and tetracyclines, valproic acid, which is used as anti-epileptic drug, methyl dopa, which is used in case of Parkinson's conditions like or hypertension conditions, hormones, estrogen hormones, furosemide, the diuretic, pentamidine and aminosalicylic acid compounds, also corticosteroids. These are known to produce pancreatitis. Worldwide, the incidence of acute pancreatitis ranges between 5 and 80 per 1 lakh population, with the highest incidence recorded in the United States. The overall mortality in patients with acute pancreatitis is 10 to 15%. So, with all the advanced technologies of treatment, the pancreatitis outcome is not so good. Mortality rate is 10 to 15%. As far as the etiologies of pancreatitis in children and adolescents are concerned, in addition to those basic issues which we have considered, the other factors like a systemic disorder like cystic fibrosis, Crohn's disease, rheumatoid pathology, these also are known to trigger pancreatitis in case of children. Or abdominal trauma, it's common for both. Vascular diseases are common, and structural, most important is the structural, where there could be an abnormalities of the shape of the pancreatic tissue. Infections, enterovirus, salmonella, the typhoid-like conditions also are known to produce the pancreatitis-like conditions. Then metabolic, of course, genetic, they are common for both adults as well as the children. The commonest clinical presentation of acute pancreatitis is the most common clinical symptom would be fever, which is seen in 76% of the patients, and tachycardia, and followed by hypotension. There is a tendency to present it as a shock. Then acute abdominal tenderness, muscle guarding, the pain would be quite significant, acute, and it presents with the significant guarding as well as the distension of the abdomen. Or then paralytic ileus, absent or diminished bowel sounds also are commonly seen. So often it produces a confusion with the intestinal obstruction pathology. Pancreatitis often produces confusion with the intestinal obstruction pathology. Jaundice is seen in a few of the patients, is around 28%. Dyspnea, tachypnea, basilar rales, that's basilar rales like crepitations in the lungs, these also are known to present with that. And acute pancreatitis often presents with the collection of the fluid in the pleura. So there could be signs of the pleural effusion, which we consider as a complication of acute pancreatitis. Severe cases, there could be hemodynamic instability, that is the shock-like conditions, hematemesis or melena, and the patient would be pale, there would be sweating, and hence again it may produce confusion with the any other shock-like conditions. Extremely muscular spasms may produce hypocalcemia. It's a rare. The severe muscle spasm secondary to hypocalcemia can occur in cases. The other typical standard clinical signs which are mentioned in the textbooks are One is the Cullen sign, which is a bluish discoloration around the umbilicus due to hemoperitoneum. Presence of the bleeding into the peritoneum produces a bluish discoloration around the umbilicus, which is called as Cullen sign, or Great Turner's sign, where there would be subcutaneous hemorrhagic spots, very often in the flanks, or it could be anywhere, very often in the flanks. It's also due to the retroperitoneal blood dissecting along the tissue plane. It's the common other standard clinical signs. Not necessary that every patient would have these signs, but whenever these signs are there, that suggests about a severe and acute pancreatitis conditions. Another other clinical symptom would be the erythematous nodules. There could be patient may develop erythema in the limbs with somewhat hardening, thickening, nodular appearance of this erythema also can occur. Because the patients would have acute pain and characteristically the pain is referred to the back, the patient would be having comfort in a flexed position. So patient prefers to keep the body in a flexed position. So a patient with acute abdomen who prefers to sit in or lie down in a flexed position, keep the head or the back bent forwards, you may suspect pancreatitis, one of the important clues. Acute abdominal conditions. In other conditions of the acute abdomen, the patient prefers to stretch the body, keep the body straight. That produces more comfort. Whereas in case of the pancreatitis, because of the involvement of the posterior surface of the peritoneum, retroperitoneal structure, the spasm of the paraspinal muscles would occur, and hence this position is a characteristic. So that's the other clinical sign by which you make out. Pancreatitis is diagnosed with lipase and amylase enzyme levels. Of course, in earlier days, lipase and amylase level were considered as the benchmark to make the diagnosis. But now the current guideline says lipase and amylase is not the essential condition. There could be many patients who have lipase and amylase levels at the normal level, but still there could be a pancreatitis. When you assess the pancreatitis, these lipase amylase levels, pancreatitis risk is when the lipase level is more than 200 units per liter, or amylase level also is more than 200 units per liter. But acute pancreatitis, a diagnosis of acute pancreatitis is made only when the level is more than 3 times the normal. That's why it has to be essentially amylase level has to be more than 420, and lipase level should be more than 450 units. Then only the diagnosis of acute pancreatitis is made. There could be many other reasons which can result in increased pancreatic enzyme levels. So lipase and amylase levels are not considered as the standard now. Earlier in 80s, we had considered lipase and amylase level as the diagnostic entities. But now it's known that there could be many other conditions which can produce a rise in the pancreatic enzyme level, and hence and the diseases which can produce these are many, like biliary tract diseases, intestinal obstructions, mesenteric retractions, peptic ulcers, appendicitis, pancreatic cancers, ruptured ectopic pregnancy, ovarian neoplasm, as well as non-abdominal causes like salivary trauma infections, or thoracic myocardial infections, pulmonary embolism, pneumonia, or metabolic pathology like diabetic ketoacidosis, or drugs like opiates, phenylbutazone, trauma, or renal disorders, or of course macromegalemia is a pathology related to the pancreas only. Then the lipase level could also be raised in pancreatic cancer, non-pancreatic abdominal pain, or lipemia, renal insufficiency, and so on. So because of that, the current trend is not to consider lipase and amylase level as the criteria to make the diagnosis. But still, if the level is very high, like more than 3 times the normal, then that could be considered as a definite sign of the acute pancreatitis as such. So pancreatitis now is better diagnosed with the imaging studies, and the benchmark diagnosis would be by MRI scan. MRI scan is considered to be the standard method where you can see the pancreatic edema as well as if there is a possibility of necrosis of the pancreas. See, initially in the early stages and a mild pancreatitis, it will be only the edema of the pancreas which is seen, but later on it can result in the necrosis, as well as another major complication of the, or another major issue which is produced due to pancreatitis is the collection of the fluid. Collection of the fluid in the retroperitoneal area, or it could be collection of the fluid in the peritoneum, or it could be collection of the fluid in the pleura. But this collection of the fluid produced are in the perirenal space. This collection of the fluid can be better made out with the MRI scan, and hence MRI scan is considered as a benchmark. Necrosis of the pancreas also can be made out with the MRI scan. So MRI scan is the standard protocol. Though USG also can make out the diagnosis of pancreatitis, accuracy level of USG is lower, and the USG may not be able to make out whether there is a real necrosis or not to a certain extent, and hence MRI scan is considered as the standard technique of making the diagnosis of pancreatitis, though USG also is quite good enough. The accuracy level is comparatively lower, but in the USG also you can make out the same issues, the edema as well as the necrosis or the fluid collections can be made out, but accuracy of the investigation of USG is lesser than that of the MRI, and hence MRI is the most preferable investigation. In all cases of pancreatitis, your approach to the management is based upon the assessment of the severity. Your approach to a mild pancreatitis and a severe pancreatitis would be always varying, and hence it has to be the assessment has to be made out about the severity. And another quite important is pancreatitis is a condition where the course of the disease can be quite fast, and your approach to the management also would be depending upon the course of the disease, and hence assessment of the severity is one of the criteria. The severity could be assessed by different standard parameters, and one of the parameters is radiological, CT or MRI evidences, or even USG also can do the same, and usually the degrees or the scores are given as if a normal pancreas 0, enlarged pancreas 1, peripancreatic inflammation, if there is a fluid around the pancreas, that inflammation, then there is the score is 2. If there is a pancreatic fluid collection, acute peripancreatic collection, fluid collection, in one area, then 3, if it is more than 1, 2, then it is 4. Similarly, if there is a necrosis, again the scores are added by 2, 4, 6, and then you have to make the total assessment, and based upon that you have to decide whether the patient is mild or severe. Then of course the fluid collection in the pancreas is due to the same, the trypsinogen, which I have referred to in the beginning when we discussed about the physiology. Trypsinogen normally is presented in the pancreatic cells, and when it reaches the intestines, it gets activated into trypsin by many of those factors. One is of course this pancreatinase, enterokinase enzyme is the other one, and it gets converted into the same. But if at all there is a intracellular digestion in the pathology of the pancreatitis, what happens is trypsinogen gets activated in trypsin within the pancreatic cell, and because of that, the pancreatic cells, the trypsin is activated, it starts the digestion of the pancreas. So pancreatic cells, they tend to get digested, and that's the most troublesome complication, and that's the most troublesome event which can produce a significant change in the course of the pathology. So activation of trypsinogen into trypsin within the pancreatic cells due to that inflamed changes, and there is a secretion of lysosomal granules, and this produces further, once it starts digestion, once that process starts, it's a vicious cycle. It goes in further. The more and more trypsin would be broken down, because once it starts digesting the components of the cells, all that granules which present with the trypsin, they tend to get digested, and that results in liquefaction of the pancreas as well as any of the tissue which comes in contact with, and that results in the fluid collection. So in a operative finding, when you open the abdomen, inflamed pancreas, which shows that necrotic changes, early necrotic changes, and the collection of the fluid around. This is a typical presentation of an acute pancreatitis intraoperative findings, and that's the most dangerous issue also, because trypsin is a very powerful enzyme, and if it leaks into the peritoneum or if it gets into the system, it can produce the digestion of any of the organ, and that's why pancreatic surgery is always considered as a high risk surgery. Handling of the pancreas in any surgical conditions, rather, it's not only the pancreatic surgery, in any other abdominal operations, handling of the pancreas has to be extremely careful, and if there is a mobilization of pancreas, it can result in the same issue, like the trypsinogen may get activated into trypsin within the pancreas, or it may get leaked into the area and produce the digestion, autodigestion, which is quite severe. Clinical present is assessment. The scoring of pancreatitis, severity of the pancreatitis is also done by the CT index or clinical index. See, of course, this is a repetition of the same. Or Glasgow criteria, that's another clinical criteria. As the Glasgow criteria, clinical made out by based upon the investigations, and that criteria predicting the prognosis of pancreatitis would be: if the patient has arterial oxygen pressure of less than 60, or age is more than 55 years, then WBC count is more than 15,000 as such. Calcium level is less than 8 or more than 8, there is altered calcium level. Hypocalcemia can be a consequence of acute pancreatitis, whereas hypercalcemia is a cause for pancreatitis, and hence this is one of the important issues. Blood urea nitrogen having more than 44, or glucose level more than 180, or serum albumin level is around 3 or less than 3. These are the other criteria by which you can make out the severity of the prognosis is pancreatitis. And the criteria is, if more than 3 criteria are present within first 48 hours of the presentation, it's considered to be severe pancreatitis. So the rule is, a patient is once the patient comes in, you have to get these investigations done. Of course, age is not an investigation factor, and if the changes occur rapidly and there is a continuous change once in 3 hours, like a mobilization, like, then it's considered to be within 48 hours there is a changes, like, then there is a possibility that the patient may have a severe pancreatitis, and the approach has to be different. Now, approach to the diagnosis of pancreatitis, as I told you, it's not only the diagnosis of pancreatitis, it's also necessary that you have to assess the severity and plan the diagnosis. So, severity of the diagnosis is based upon either a clinical diagnosis as well as the etiological factors. So, once you have a patient of suspected severe pancreatitis, you have to have the diagnosis based upon the same parameters, clinical parameters, maybe imaging or maybe the biochemical, as well as you have to make out the diagnosis related to the etiology, particularly hepatic workup, liver pathologies, and stones in the gallbladder, or triglycerides level, calcemia. These also have to be ruled out, and they help to make the diagnosis. And once you have made the diagnosis, you have to make out the severity index. If the condition is severe, there is a possibility of organ failure, and the patient has to be treated with a multidisciplinary approach, and the patient has to be shifted to ICU. Whereas a mild pancreatitis doesn't require that, and the treatment would be, in a case of mild pancreatitis, if you have confirmed that it is a mild pancreatitis where the score is less than 4, then our radiological score is less than 4, then it can be managed medically, and the conservative management is initially it should be fluid, IV fluids. Then, of course, earlier criteria was the patient had to be kept in nil orally, but now the suggestion is patient has to be encouraged to have oral food as early as possible. If the patient is not able to take the food orally, enteric feeding also is suggested, like put in a tube and then through that you have to feed as such. Repeat the ultrasound, and then if there is no evidence of gallstones, then the patient can be managed with only fluid resuscitation and maybe the symptomatic treatment for the pain. And of course, such conditions definitely can be effectively managed with our drugs, like Mrityunjay Arogya Kumari as well. And I have seen many patients where we can definitely manage these patients effectively. Only thing is you have to be watchful for the progression of the disease. If the patient goes into the next stage, the severe conditions, then probably our treatment may not be sufficient. You may have to go for the other possible treatment. If you have considered this as a severe pancreatitis, or if the diagnosis is made as severe pancreatitis because the score is between 4 to 8 or 4 to 6, then it requires intensive medical therapy, which has to be mainly the IV fluids in aggressive amount of IV fluids, large amount of IV fluids are necessary to reduce the possibility of autodigestion. The glucocorticoids also are indicated, as well as plasma expanders like dextrans also are given to reduce the possibility of the necrosis as such. If that's lexicant is a sort of the same like dextrans, different sorts of the dextrans given, by which the digestion, autodigestion can be reduced, and or antiproteases now they are available, very high sophisticated injections also are given to reduce that protein dissolving tricks in dissolving substances, tricks in the system, and it has to be, there is always a possibility of later complications like necrosis, pseudocyst or abscess, and they have to be watched for, and their treatment has to be done. If it is a necrotizing pancreatitis, then it has to be in ICU, where there is always a possibility of multisystemic involvement, which can result in either a sterile necrosis or infected necrosis, which may even require surgical debridement. A pancreatectomy also may be needed, and the prognosis is extremely poor. In a necrotizing pancreatitis, prognosis is extremely poor, and you need to have more effective management, and the patient has to be in ICU. Multisystemic, there is always a possibility of multi-organ failure. The surgical indications, of course, the patient, in a case of acute pancreatitis, the better option is a non-interventional approach. A conservative approach should be preferred as far as possible. But surgical indications are needed, or surgical interventions, or maybe other interventions are needed if the patient has developed either abdominal compartment syndrome, that's a severe fluid collection in the abdomen, which results in a failure of respiration, or respiratory movement may be reduced. Then acute ongoing bleeding, if the patient has persistent bleeding, then and your administration of the drugs may not be successful in that condition. If the patient has developed ischemia due to necrotizing cholecystitis, the whole area has become necrotized, in that condition surgery is needed. If the patient has developed a intra-abdominal fistula, the same digestion, autodigestion, if it results in the fistulas, very serious complications, and of course outcome of the surgery also poor. ERCP, endoscopic retrograde pancreatography, is done with acute gallstone pancreatitis. It's in gallstone pancreatitis, it is not indicated, and whereas routine, it should not be done as routinely. Only in case of the acute gallstone pancreatitis and cholangitis, it is indicated. That's the guideline as such. The common complications which can occur due to the pancreatitis are the same as acute fluid and electrolyte changes, fluid collections in the peritoneum and pleura, which can result later in case of the cyst formation, bleeding into the gastrointestinal tract, necrosis of the pancreas resulting in a total pancreatic failure, systemic inflammatory response syndromes where multi-organ involvement would occur, which is again a acute emergency. Patient needs to be treated in ICU, or it could be fatal complications. The patient may result in hyperamylasemia, persistent increased level of MLS. Hyperamylasemia we will discuss separately later with all the other causes also. There could be extensive peritonitis, and it can result in recurrent chronic pancreatitis. Stones could be formed. Pseudopancreatic cysts of acute or chronic nature also could occur due to acute pancreatitis. That's about the acute pancreatitis. The next is about pseudocysts of the pancreas. I think we will take up this in the next session. Pseudocysts and chronic pancreatitis we will continue in the next session. If there are any questions, we will try to answer and then conclude today. There is one question. Sometimes Talisadi Churna increases dyspnea and cough. Yeah, of course. It's not related to pancreatitis-like conditions. In any patient who has a dry cough-like conditions where there is not much of a sputum, Talisadi may aggravate. So Talisadi is indicated when there is more fluid or kaphaja kasa. And in such conditions, Sisapaladi may prefer. If Talisadi aggravates the condition, you go Sisapaladi. That's the other way. Of course, it's not related to the pancreatitis and the cystic fibrosis condition. Right? Then any other issues? Right? So we'll wind up today.